Good day, so this is the demonstration video for Myotome, Dermatome, and Reflex testing assessment. So let's begin with dermatomal testing. For the grading, we utilize 0 for absent, 1 for altered, 2 for normal, and NT for not testable. This would mean that the joint may be contractured, the limb may be amputated, or there is an acute wound or injury that does not allow testing. So we test the cervical to the sacral segments. So in dermatome testing, we test for light touch and pinprick sensations. The tool to use is your neuro hammer. For light touch, it is the brush end tip. So first, let's take a look at your upper extremity dermatomes. So this is from your cervical level up until your upper thoracic levels. C5 is for your deltoid area, the anterior aspect of your entire arm to the base of your thumb. C6 is for your anterior arm, the radial side of your hand to your thumb and index finger. C7 is your lateral arm and forearm to your index, long, and ring fingers. C8 is for your medial arm and forearm to your long, ring, and little fingers. T1 is for the medial side of your forearm up to the base of your little finger, and T2 is the medial side of your upper arm to your medial elbow, pectoral area, and your mid-scapular areas. So in testing for light touch, you usually run the brush along the areas of the dermatome. After assessing for light touch, you must assess all dermatome levels again, this time for pinprick sensation, and you use the sharp end of your neuro hammer. For pinprick sensation, instead of running it through the entire dermatomal area, you just choose the most sensitive areas to do your testing on. For C5, this is the lateral upper arm or your deltoid area. C6 is your lateral forearm. C7 is your index finger. C8 is your little finger or the ulnar aspect of your palm. T1 is your medial forearm. And T2 is your medial upper arm. Now do this on the other extremity as well. For the thoracic dermatomal levels, here are some important landmarks. T2 is for your level of axilla, T4 is for your nipple line, T6 is for your xiphoid process, and T10 is for your umbilicus. Now we have your lower extremity dermatomes. Initially, we assess for light touch using the brush end of the neuro hammer. L1 is for your trochanter and groin area, as well as the posterior portion of that area. L2 is for the front of the thigh towards your knee, as well as the posterior aspect of that area. L3 is for your upper buttock, anterior thigh and knee, medial lower leg, and posterior aspect of that area. L4 is for your medial buttock, lateral thigh, medial leg, dorsum of the foot, and your big toe. L5 is for your buttock, posterior and lateral thigh, lateral aspect of your leg, dorsum of your foot, medial half of the sole of your foot, and your first, second, and third toes. S1 is for the lateral aspect of your foot, your little toe, and the posterior aspect of your heel, as well as the posterior aspect of your leg. S2 is for the posterior aspect of your thigh, going up towards the buttock area. After assessing for light touch, we again assess all dermatomal levels of the lower extremity for pinprick sensation using the sharp end of the neuro hammer. So L1 is for the anterior upper thigh, so compare sensations on both limbs for all dermatomal levels. L2 is for the middle anterior thigh. L3 is for the medial aspect of the lower thigh. L4 is for your medial malleolus. L5 is for your big toe area. S1 is for the heel or the plantar aspect of your foot. And S2 is for the back of your upper thigh. For the sacral segments S3 to S5, it is in the perianal region. Next, we have your myotomal testing. So this is testing for muscle strength of various movements. So here is a list of all the myotomes from your cervical up until your sacral level. In scoring these myotomes, you have 0 for total paralysis, 1 for palpable or visible muscle contraction, 2 for active movement with gravity eliminated, 3 for active movement against gravity, 4 is for active movement against some resistance, 5 is for active movement against full resistance, and 5+ is normal corrected for pain or disuse. And you also have NT for not testable. So remember that in testing for myotomes, it is important that you test each movement bilaterally. So both left and right sides need to be tested. Instructions are generally the same, So for C5, it is shoulder abduction. Just ask the patient to abduct their shoulders and resist the movement. Next, you have C6, which is for elbow flexion. So you resist elbow flexion movement. Also, another component is wrist extension, so you must also test that movement by adding resistance. C7 is for elbow extension, so test that movement by adding resistance towards elbow extension. Another component is also wrist flexion, so to complete the testing for C7, you must also resist wrist flexion. Next, for C8, you have thumb extension and wrist ulnar deviation. For T1, it is finger abduction. Just ask the patient to resist your movement, which is trying to open apart the hands or fingers. L2 is for hip flexion. You may do this in sitting position, one at a time. Resist hip flexion with the knee flexed. You may also do this in supine position. L3 is for knee extension. Resist extension each leg. You may also do this in supine position. L4 is for ankle dorsiflexion. You may test this in sitting as well. Remember to test both sides. You may also do this in supine position as well. L5 is for big toe extension. Just resist big toe extension. You may do this in sitting, and you may do this in supine position as well. S1 is for ankle plantar flexion. Resist plantar flexion movement in sitting position, and you may also do this in supine position as well. S2 is for knee flexion. Resist knee flexion movement bilaterally in sitting, as well as you may do this in the supine position as well. Usually, myotomes are tested in sitting position, but if the patient's condition doesn't allow them to sit upright, you may test them in supine position. So it's on a case-to-case basis, and you need to analyze if it is appropriate for your patient. The last part of assessment is your reflex testing. So you test for your biceps, brachioradialis, triceps, quadriceps, and Achilles tendon reflex. For the grading of your reflex or deep tendon reflexes, 4+ is for a very brisk response and clonus, 3+ is for brisk response, hyperreflexia, 2+ is for active response or normal response, 1 is diminished response or hyporeflexia, and 0 is absent. The tool we use to elicit reflexes are your neurohammers. The first reflex we have on this list is your biceps reflex for the level of C5 to C6. So you need to palpate the biceps tendon, and you do that by asking your patient to repeatedly pronate and supinate their arm in a slightly flexed position of the elbow. Once you palpate your tendon, ask your patient to look away and briskly tap on the tendon. So you should not elicit pain. Response is elbow flexion. You may also do this in a sitting position or in a supine position, or the patient's condition doesn't allow them to be upright. So it's the same thing. Palpate your biceps tendon, slightly flexed position, and tap on the tendon. For your triceps reflex, ask your patient to extend their elbow and locate the triceps tendon. Ask your patient to look away and tap on the tendon briskly. You should not elicit pain, and response would be for elbow extension. You may also do this reflex in a supine position. Ask your patient to cross over their arms, palpate the tendon, ask them to look away, and briskly strike the tendon. A normal response would be a jerk action towards elbow extension. Next, you have your brachioradialis reflex. Palpate the tendon, maybe at the proximal point or the distal point, by having them with a flexed elbow supinate the forearm, or you can also have a bit of radial deviation. So strike the brachioradialis tendon midway near the wrist or near the elbow. Normal response would be a flexion and a supination movement of the wrist or forearm. Next, you have your patellar reflex. The patient here is instructed to clasp their hands together for Jendrassic maneuver, which allows for easier eliciting of the reflex. So ask your patient to extend their leg to help you palpate or locate your patellar tendon. Once that is located, ask your patient to look away and tap on the tendon briskly. Normal response would be knee extension. So test on the other side as well, and this may also be tested in the supine position. Next, you have your Achilles reflex. So this is tested by palpating your Achilles tendon, which is at the back of your heel. Once that is palpated, dorsiflex the foot passively a little bit and then tap on the tendon so you can feel the reflex of ankle plantar flexion. You may also do this in the supine position by having the patient cross their leg over the other leg. So remember, in myotome, dermatome, and reflex testing, you must always assess each limb bilaterally. For dermatomal testing, assess for light touch and pinprick sensations. Ask the patient to close their eyes or to look away, and ask them to describe the sensation. For myotome testing, just remember to resist both sides of the limbs and ask them to maintain the position while you add a counter resistance force. For reflex testing, in order to properly palpate the tendon that you need to test, have the patient perform the movement or action of the muscle. So the biceps tendon, for example, can be palpated with the arm slightly flexed, and you have the patient do pronation and supination movement of the forearm. Before tapping on the tendon, ask the patient to look away, or they may do the Jurassic maneuver by either clenching their teeth or clasping their hands together, and then you strike the tendon to elicit the response. So these types of assessments are important for determining which spinal level was injured by any kind of pathology. So make sure that you review your spinal levels and which nerves exit from which levels, as well as the level of your dermatomes, myotomes, and your reflexes. And that's it for this video. Thank you.